in the elderly. And the main idea is to obtain a stable reduction to get good internal fixation in a good position, which is mechanically adequate. Because the main idea of these fractures in the elderly is to get them up and about. So you should permit immediate transfers and early ambulation. So basically, proximal femur fractures, other than the neck fractures, which is a different entity altogether, consists of these trochanteric fractures, the extension onto the subtrochanteric region, and subtrochanteric fractures. And I think there's a bit of overlap between the two, so that's why I'm going to cover them together so that there is no confusion about what we are talking about. So one must understand the concept of stability in the trochanteric fractures, which is the ability of the reduced fracture to support physiological loading. Okay, so if you can get a reduction that is stable, I think any kind of fixation that you do is likely to work. If your reduction is not stable, then you have problems and you have to think about how you will deal with this problem. And remember that fracture stability relates not only to the fracture of fragments, but the fracture plane as well. So not just the fragments, but the plane as well. So you have a fracture like this. If you do a CT, you can see that there are multiple planes of fracture, including coronal plane fractures. And this is very different from a simple intertrochanteric fracture that we have to deal with. Now, if you look at the AO classification, all these are A-type fractures, and you have A1, A2, and A3 in increasing order of instability. So as you start from 31A1, these are the most stable, and the 31A3, 3 would be the most unstable variety of these. And you have a spectrum ranging from stable to unstable, which would kind of more or less go through this line. So the first 4 would be relatively stable. As you go on to the A2, 2, A2, 3, and the A3 type fractures, they are mostly unstable. Now, basically, your goals of treatment would be to get them into surgery as quickly as possible and ideally within 48 hours. But you don't want to be operating on these in the middle of the night. So you have to tune up any correctable comorbidities. That means like if the blood sugar is too high, the electrolytes, etc., you need to get them corrected. If they're dehydrated, you need to hydrate them. But try to operate early within 48 hours because that has been shown to improve the prognosis in these patients. Now you maintain, now early on is to all put them in traction, bucks traction, sometimes even skeletal traction. But what has been found is that basically if you can put the limb in a position of comfort, that is what is the most useful because you want to operate early. So it's not that you're going to leave them in traction for a long time. So ideally, just keep them comfortable. If that requires traction, that well and good, but there has really been shown to be no real advantage of bucks traction in randomized controlled trials. Similarly, we all talk about general anesthesia being more dangerous than spinal anesthesia. Really, I think there is not much difference between the two in terms of the risks as far as the surgery is concerned. Obviously, the type of anesthesia, the quality of the anesthetist and the care, the postoperative care becomes critical in the management of these patients. And therefore, management of these elderly with trochanteric fractures should really be a multidisciplinary team effort with the physicians, if necessary, cardiologists, the nephrologists, the anesthetists, and the surgeon's part is relatively actually small, but you have to make sure that you get a good stable fixation, which will allow early mobilization. But they need to be managed medically well, and this is really important. Okay, so again, communication is very important. You have to communicate to the relatives that these fractures itself are a risk, and there is a certain amount of morbidity and mortality associated with these fractures. You've all heard of the saying that we come in through the brim of the pelvis and go out through the neck of the femur, which is like a euphemism to say that some of these patients with these fractures, especially the elderly, may not survive uh, for very long after this fracture. Okay, so this is important to communicate. Is there a role for non-operative treatment? Really, if the anesthetist says there's no way we can give anesthesia, that would probably be the only situation. Or in a absolutely undisplaced fracture, you may uh, bank on non-operative treatment. Otherwise, surgical treatment is the first choice, and your success depends on one, medical optimization, which is really important, your fracture implant construct, which is important, your reduction, which is important. So reduction of the fracture, if it is optimal, then biomechanics are restored, the stress on implant is reduced, and you are likely to get rapid and complete fracture healing, because these fractures, if they are uh, if they are with good bone end-to-end contact in good position, they tend to heal quite rapidly. Now, what is the history of these fractures? Yes, earlier you had these fixed angle blades, and then the sliding hip screw, the DHS, or the Richards, the variants of this really revolutionized the treatment of trochanteric fractures, and they greatly reduced the incidence of implant failure, cutout, breakage, or joint penetration. Okay, so if you had a fracture like this and you treated it with a DHS, it really went on to heal with some collapse, but you can see that that little bit of collapse does not cause any functional problem, and this patient is able to do almost everything for her daily living, and that is an excellent result with a DHS type of fixation for a trochanteric fracture. However, there are problems with the DHS, and you can see this. It looks very good on the X-rays. The AP and lateral look good. But if you look very carefully, you can see there's quite a big void there on the towards the calcar side there. Okay. Now this is going to collapse because there will be significant collapse. And you can see that over time there's been a lot of collapse for this fracture to heal. And it's almost reached the end of that DHS barrel to collapse before this fracture is healed. Luckily, it healed in this case, but it may sometimes be beyond the ability of this fracture to heal because of the amount of collapse that it requires. Also, this collapse is not totally benign, because you do end up with abductor lurch, shortening of the abductor lever arm, and with problems with the patient will have problems with his gait and his ability to lift his leg up. So one is required to get a good healing of the fracture in as close to an anatomical position. Now, DHS works well with the traditional type of trochanteric fracture, but when you have a reverse trochanteric fracture, you can see that there will be a tendency for medialization with the DHS cannot control on its own unless you add a trochanteric stabilization plate. Okay, so you can see what happens with this kind of reverse trochanteric fracture. That's the fixation. It looks okay, but you can see how this has collapsed significantly or medialized significantly before this fracture has healed. And again, there's a limit to how much medialization, which is compatible with healing of these fractures. So the IM nail started getting more popular for treatment, and there were two reasons for this. One was the mechanical advantage, because as you can see that the nail is closer to the center of gravity and the center of the weight-bearing axis of the limb. Okay, so therefore there is less of a cantilever loading on the nail as opposed to the plate. And also the nail kind of acts as a buttress, okay? So it acts as an intramedullary buttress which resists excessive fracture collapse. So you can see this example. Here's the fracture. This has been nailed. And you can see how when it heals, the nail is actually buttressing any further collapse of the fracture. And this goes on to heal well with good function, with much less medialization than you would get with a DHS in this same situation. Now, when you have subtrochanteric extensions, then it becomes even more of a problem with the DHS. You can see that this has been fixed with the DHS, okay, with multiple screws. This was an old case, but you can see how because of the cantilever loading on this fracture and the DHS not being able to resist it, the DHS has gone on to break. As opposed to the nail, when you have fractures such as this, if you can nail them in a good position, it's minimally invasive and it will go on to heal well, as you can see here, or in this case with a much more comminuted fracture. Again, nailed with this long gamma nail in this case, you can see how this has, in spite of the multiple comminutions, gone on to heal satisfactorily without any significant collapse at all. So the IM nailing definitely has some advantages in that it is biological, it is minimally invasive, it's biomechanically more stable, and it generally, if you look at all the studies, it does allow earlier full weight bearing. Okay. However, if you look at things like union time, blood loss, intraoperative complications, infection rates, etc., they are debatable because depending on the study, you will find different results. And really, there's been no conclusive evidence that the blood loss is less or the mortality rate is less, etc. And the eventual functional results are also not much different. We don't know for sure. In certain fractures, it probably does make a difference. But if you look at them overall, the difference which has been shown clearly is really minimal. However, nailing is not always a great way to treat these fractures. It is not a magic stick. And if you try to nail these fractures in an unreduced position, you're going to have disasters. And we can show you multiple disasters, but this is not the aim of this talk. The aim of this talk is to try and show you how to nail them satisfactorily. Okay, now, so what are the requisites? I think reduction is really critical because if you see these fractures, they are usually in a incorrect position. And when you try to get your entry point, unless you've got the proximal fragment in a reasonable position, you're unlikely to get the correct entry point. And if you do not get the correct entry point, you will have problems. Secondly, you need to ream adequately so that the nail does not need to be hammered in. It can be gently pushed in with maybe at the most a little bit of a tapping right at the end. And you must get a proper positioning in terms of varus, any flexion, extension, etc. at the fracture site. Now, what you have to be careful of is when you give traction and you don't give any traction on the normal leg, you will end up with abduction of the hip or the pelvis, which makes it difficult to then get the entry point, the correct entry point for the nail. So this is something you have to be careful of. You may have to adduct the limb to get the entry point correct. Second thing is you must get this entry point right. And your entry point is towards the medial side of the trochanter. It's not in the piriformis fossa, not for the nails that we use for the trochanter, which are quite thick on top, although they are trying to bring it down in size with better metallurgy, but it's still too large to go into the trochanteric fossa without causing possible damage to the blood supply. So we still try to go for the tip of the trochanter, but on the medial side of the tip of the trochanter. The second thing is, if you have a fracture which is extending into the trochanter, then your reamers are going to lateralize the entry point. And as you ream, the reamers will go through the fracture. So you need to and spread the lateral part of the trochanter out. So you need to press on the lateral part of the trochanter to keep it in the correct position. So here's an example. This is a trochanteric fracture where we've planned to nail it. And you can see when we are trying to put the guide wire, it tends to go into this fracture area. And you have to be careful to make sure that your entry is actually on the medial tip of the trochanter, as you can see there. And then throughout the process of reaming and putting the nail, you have this mallet which is pushing on the trochanter to make sure that that part of the trochanter is not splayed laterally. Okay, so you can see that until you put the nail in and you get this jig into the correct position, which is compressing on the lateral cortex of the proximal femur, you should not leave that hammer. Okay, so you can see now how the guide wire is going in the correct position. We complete the nailing and this goes on to a good position of the nailing, which will likely to heal satisfactorily. If you don't do this, you will get displacement of the lateral wall. The nail will tend to walk into the fracture, as you can see in this case, and then this will go on to fail. Or for example, here you can see how the nail has gone into the fracture. The tip of the trochanter is displaced medially, while the lateral wall is displaced laterally. You can see there's a varus, and this will then end up with the nail breaking in this case because of the cantilever forces and the varus that it creates. So these are things that you have to be careful of and make sure that when you nail them properly. Other thing is to get the valgus angle right. Now, when you're passing in the nail, you usually have to adduct the limb. But once you've got the nail in, you can abduct. So if you find that you're getting a varus deformity, increase the traction and abduct the limb. That will usually help you correct the varus. Okay, so you can see that position where the nail guide wire would be going. And once you give the traction, you will get the guide wire in the correct position, and abduct the limb, you will get the guide wire in the correct position. And then you will have the right position of the proximal femur for your nailing. The other thing that really has become very important today is the use of wires. Okay, so if you have a fracture like this, just one cerclage wire, you can do this open or you could do it minimally invasive. And once you put this cerclage wire, nailing this becomes much easier and you get a much more stable nailing. Here's another example. Now, when you have something like this where the trochanter is off, then you need to also uh, wire the trochanter part. Okay, so you can see that how we've wired the trochanter and the femur, and what looks like a really difficult fracture to nail has then gone on to do well. As you can see in the subsequent follow-ups, you can see how the fracture is healing well. It's gone on to heal completely. And you can see he's got a good function. There's an elderly gentleman, and you can see he's walking almost without a limp, and he's able to stand on and almost squat properly. So you can get very good results even with these elderly patients if you can do a proper job with the nailing. Remember, with subtrochanteric fractures, the forces that are there in the proximal femur are very great. And Koch in 1917 showed that there's almost 1,200 pounds per square inch can be generated by a 200-kilo man. Okay, so you can see that this patient, the amount of forces in that region are great, and this is related to the muscle forces which act on it. There's a flexion of the proximal fragment, abduction and external rotation of the proximal fragment by various muscles, and also this will cause problems with your reduction. So you can see here, this is a fracture which extends to the subtrochanteric region. If you look at the proximal fragment, you can make out that it's flexed, it's abducted, and it is externally rotated because the lesser trochanter is very prominent. You can see that situation. And what you need to do is to use a joystick, put it into the proximal part of the femur, rotate it, get it reduced, and then get the correct guide wire position. And once you do that, then everything becomes easy because then your nailing does well. You can use other methods to get your reduction. Use these pointed uh, sort of reduction clamps. You can use these hooks. You can use the pusher, etc., the spike disc pusher, and these will help you with your reduction. And today you also have the collinear reduction clamps, which you can use to get your reduction. Make sure you got the reduction before you start passing your guide wire. You can also use the nail to help you with the reduction, but this is for more distal fractures. Don't try that for more proximal fractures and in very osteoporotic bone. So the use of the cerclage, and today you have these minimally invasive cerclage reduction tools. So you can see this example. This is a subtrochanteric fracture. You can see it extends till very close to the trochanter, but goes down quite a way. You can see that position on the table. And all we do is to pass this cerclage wire introducer. You can pass the wire in and out, and then you can tighten these wires. There's a special instrument to tighten the wire, and then you have a reduced femur. And it's like almost nailing a intact femur. It's very easy to nail. There you can see how the nail has been passed. And believe it or not, these cerclages do not interfere with healing. You can see how this has gone on to heal. And you can see the amount of bone thrown at the area of the cerclage wire. So one cerclage wire, if it's passed properly, does not impede healing. It does not affect the blood supply. And today, there have been multiple studies to confirm that. In fact, there have been studies in dogs which show that the cerclage increases the blood supply in that region if you haven't devastated the soft tissue when you're putting the cerclage. So here's this case which I showed you earlier. This is a patient we just did today. You can see the kind of fracture, and these are fractures which some people would resort to primary arthroplasty because of the osteoporosis. It's a very elderly patient with multiple comorbidities. But you can see with the use of the wire and the nail, and these are the CT scans showing you the kind of displacement of the trochanter. And if your trochanter is completely displaced like this, then you need to wire this into position. You can see how we have nailed it and also put a cerclage through the trochanter to keep it in place. And this is just a Shyam image because we haven't yet got the x-rays, but you can see how beautifully this is reduced and is well. Unusual case, this is a patient who had multiple fractures, had an infected nail with a non-union of a shaft of femur, which we had earlier done a masculine technique in and got it to heal well. And now he came with this fracture in the subtrochanteric region. And we had a real problem doing this. You can see that fracture there. We did an open reduction, but what we did was we just took out the proximal screws in the plate. We passed a nail, and it was interesting. It was really hard to ream because this patient probably had a minor form of osteopetrosis. The reaming was really difficult, but we managed to get the reaming done. We got a 10 size nail, so we passed a short nail. Then we managed to put an interlocking screw into the nail through the plate and also added another screw through the second plate in the trochanteric region. And this was what we were able to achieve. This was just done a couple of days ago, so we don't have all the follow-ups on this patient. And one third patient, again, these are all three very recent cases where we had this patient who had this nail done elsewhere, and she was just not unable to walk. And then finally, almost after 2 years, they removed the nail, and then within a few days of that, she fell again, and this was what she came to us with. With this kind of horrible fracture, separated fracture here, which was probably the first fracture not fully healed, and a second fracture here. And here we used a combination of wiring and a long nail and cement. Okay, so we used cement in the nail, we used a long nail, and we used this wire, and we were able to get her to walk on that. And she wasn't able to walk at all before. So this was a fairly good, she was very happy with the fact that she was able to finally stand up and walk with a walker. Again, this is very early days, so we do not know the follow-up of this patient. So there is increasing data to support the use for these nails in unstable fracture patterns. It does cause improved anatomy and early function. And the iatrogenic problems which you saw with the nails earlier, and we have a lot of patients with complications with nails, that has been decreasing as current designs improve, the techniques improve, and people are more familiar with doing the nail. However, there are certain unanswered questions. What should be the proximal diameter of the nail? What should be the length of the nail? Is distal interlocking necessary? Should the proximal screw be 1 or 2? What should be the real answers? And really, these questions are still unanswered. If you look at what we do, we tend to either go for a short nail or which the nails are straight, so we go for the really short ones, or we go long where the nails are curved. Okay, so it's the in-between size, the 200 millimeter nails, which if they're straight and then tend to hit the anterior cortex because of the curvature of the femur in these elderly. Okay, so these are things, and we tend to use dynamic locking for every case that we do rather than static locking. So that's our practice. However, these questions are still really unanswered. Okay. Now, there are certain contraindications. I think really young patients, you would rather use screws than the kind of bolts that we use. Basal neck fractures are probably better treated with the DHS. Stable fractures which require open reduction, I think we tend to favor the implant, the plates for these, especially the DHS, wherever we need open reduction and with very narrow canals. Obviously, also, if you have abnormal anatomy due to a previous fracture, as in this case, you have no option because you can't get a nail in there. Or you have something like this where the implant with multiple screws are there, and trying to get a nail in means you have to take out all these screws which broke by the time we could take out the implant. And then we had to put in this DHS with these multiple screws still there and with cement augmentation to get a good hold on this. And we were able to get this patient up and about. But remember that treatment doesn't end with the fracture treatment. You need to prevent falls. This may require a proper review of their medication, a review of their home environment, the safety features at home. You need to treat the osteoporosis. Again, this is important that you need the responsibility of the orthopedic surgeon does not end with treating the fracture or fixing the fracture. You need to either give it yourself or have a physician or an endocrinologist with you who will manage the osteoporosis. And you need to counsel them about the prognosis, about future falls, etc., because some of them will come back with fractures on the opposite side. Okay, so at the end, remember, there's significant morbidity and mortality in the elderly with these fractures. You need to optimize them medically. This is important, but do the surgery as early as possible. Early stabilization is important in proper conditions. Nail has advantage in certain unstable patterns. There is even a role for primary arthroplasty, but this is limited to failures of fixation or some very usual fracture patterns where you have fractures extending into the neck, etc. That is our take on this. Of course, there are people who would nail or would do primary arthroplasty in a lot of these unstable fractures in the elderly, saying that nails will fail. But I think if you do your nailing properly or your plating properly, you can get many of these fractures to heal. They should not require an arthroplasty. Thank you all for your patient hearing, and I'm happy to take questions. Thank you.
Thank you very much, sir.
Okay.
So, while waiting for the questions, yeah, one question is there, sir.
Let me just stop sharing.
That, yes, sir.
Yeah, okay.
So, Rajan has asked about entry point, which varies in long or short PFN. Is it so? Or if so, intramedullary nailing for femur shaft fracture? Is the entry point same?
So the entry point is not dependent on the fracture as the nail, okay? So the most of the trochanteric fracture nails have a curve on them. Okay, so they're designed for entry in the trochanter rather than the piriformis fossa. Okay, if you have a straight nail, then you have no choice but to enter in the piriformis fossa. But the curve, and depending on the curve, you have to decide where your entry point should be. Most of the nails that we deal with for the proximal femur should have an entry point in the medial tip of the trochanter. Okay, for the proximal, for the shaft femur fracture, it depends on the nail design. You have a piriformis entry nail and you have a trochanteric entry nail.
Okay, so Ratan has asked about which case you do static lock in short PFN, long PFN, or femur intertrochanteric line.
So basically, as a rule, we use dynamic locking for short PFNs because we don't do it for fractures with subtrochanteric extensions, and the instability direction is slightly different. Okay, so if they tend to collapse from medial to lateral rather than from top to bottom. Okay, now for the long nails, it depends on the fracture. So if there is a very unstable subtrochanteric fracture, we would lock it statically in the first place and then, if necessary, dynamize it. But the need for that is very minimal as long as you don't leave a gap. Okay, so more or less never in a trochanteric fracture with a short nail. In the long nails, depending on the fracture patterns, if it is a relatively stable pattern, we would still dynamically lock it. But if it's a very unstable subtrochanteric extension, then we would statically lock it initially.
In long nail, is it 2 screws or 1 screw distally?
So if you are doing a static locking, then we would use 2 screws because it's always better to have the option of dynamization. And if we use just dynamic locking, then we would use 1 screw. Okay.
So is that like when you prefer, as you have mentioned, in stable fracture DHS, when you prefer DHS with TSP over the nail, sir, in
So I
trochanteric
think
fracture?
so do you know what? If you look at these fracture patterns, if you have to, so if today what my practice is really for simple fractures which you can get a closed reduction, I would nail them. But if your reduction is inadequate and you need to open them, or it's a very bad fracture, I would go to a J. So it's actually the opposite of what people say you should be doing, which is the unstable fracture patterns get nail and the stable fracture patterns get DHS. It's more to do with whether you can do a closed reduction or not. If you can get a closed reduction, then nailing becomes simple. If it's a very unstable or very badly reduced fracture and you have to open it, then I would prefer DHS in most of the situations. Of course, if it is subtrochanteric, then we would prefer nailing.
So Dr. Muthu Kumar is from Ganga. He's asked what in in some subtrochanteric fracture, it may appear reduced after positioning. In that case, you will go ahead with nailing or add a surplus, or need to start with surplus and then nail it. Your
So,
advice, sir.
if it is a oblique fracture pattern, single fracture, where you can put a cerclage easily, I think it helps because then you do not, once you've got that cerclage in, you will not lose your reduction. Okay. But it becomes less important because to do that if you are able to nail it without getting any displacement. But some of these will displace, and the cerclage is one way to make sure that it will not displace. Okay, so I would personally, in an oblique fracture pattern, okay, which especially the long obliques, I would, because there'll be some rotational problem which you cannot get rid of without putting that cerclage. And once you get that cerclage, then nailing becomes so easy that I would prefer to do that rather than not do that. And that circlage doesn't cause a problem with healing.
Anytime, sir, in subtrochanteric fracture, plating after that nailing, is it?
So I showed one case, but it is so rare that we add. I think there are a lot of people who talk about adding plates to nails every time. Uh, our practice almost, we do use wires where the trochanter is off, we will wire that. Okay. But that is enough. I have not honestly, I mean, I've talked to a lot of people and many of them don't ever use these plates, but there are some people who swear by the plates. So I don't know what the real answer is, but we haven't needed it in our practice. If you can do the nailing properly and then with the wire, just get that trochanter wired back into position, that is 99% of the times enough. We haven't needed a plate for a simple or even a very comminuted trochanteric fracture. I showed you one case, just 2 or 3 cases where we've just wired the trochanter and put the nail and they've gone on to heal well. Okay, so and almost normal gait, etc. So that's as bad a trochanteric fracture as you will get. Okay.
So
So,
for wiring, can you please explain the technique, sir, surgical technique, because that is little confusing.
so there are 2 or 3 ways now. One is the simple for the fracture reduction. Okay. So there, I think if you have a very comminuted fracture, then it's not a good idea for wiring. Okay. So simple oblique fractures, you can just get your wire across. As you tighten the wire, rotate the leg a bit, you get reduction as well as rotation correction. Okay. So that's for the trochanter. If it is off, I wire the trochanter. Then we have 2 options. One is to wire it round the shaft or round the end of the nail. Okay. So we can do either or. If you're just pulling on it, then you put it on the nail. If it's more unstable, then we tend to wire it around the shaft and then just get it there. So that is all we need. It's actually doesn't take more than 5 minutes to do if you can do it properly.
So when you are doing, sir, is it wiring first and then the nail?
No, not necessarily for the trochanter. So if we put the wire in, but we don't tighten the wire till we've done the nail. Okay, this is for the trochanter. But for the fracture reduction, we put the wire first and then do the nail. Okay, so they're 2 different things. Yeah? So the trochanter, we
Sir,
pass the wire, but we actually get the nail in, get the guide wire in, pass the wire, get the nail in, because otherwise that wire can get stuck in your nail and cause problems.
yes.
Okay.
Yes. Yes. So Sah has asked about, is there any role of medial buttress plate?
Medial buttress.
In which case, Saha, is it subtrochanteric or trochanteric? Please unmute and ask. Okay.
Medial buttress, are you talking about an intramedullary plate?
Sir,
The medial buttress plus one conference I have shown, saying that there was a medial plate also used in neck femur fracture most
Okay,
probably.
neck femur is
neck
different.
of the
Okay,
femur. Okay.
that's different. Okay, so there you have to do an open reduction and put a small plate as a medial buttress. We have only done it once so far in all these years, and that was a fracture dislocation of the hip with a basal neck fracture. Okay, so it's not something which I use very often, but the Americans are very hot on that. Okay, and
Thank you.
there were some other questions which
Yes.
just popped up.
Sir, yeah, Dr. Muthukumar has asked what instrument you have shown is wiring. For the wiring is from
Yeah, that's a
Synthase or
synth. Yeah, ours is from Synthis, but I think now there are Indian companies which make it. But initially, when they came, it was from Synthis, and we got that,
yes, sir.
so it's still functional at the moment. So we still use that, but we don't use it for every case. We use it for very selective cases. But you don't, and for many of these cases, there are other ways. You can use your simple wire passer and do it. Okay. So it's
Yes,
not
sir.
always that we use this instrument. So if you don't have the instrument, don't worry about it. There are other ways of, but you have to be careful when you pass the wire that you don't catch any of the vessels. So be close to the bone. That is really important when you're passing the wires.
Yes, sir. One report was there, sir.
In
Two
fact,
to three cases.
Ganga had 3-4 cases of it. You can
Okay,
check with those guys.
sir.
Yeah.
Yes, sir. Okay, sir. Sasat has asked, TSP or surclass, how to decide, and which is better in terms of blood supply?
So blood supply, definitely the wire is very simple. For the trochanter, this is for the trochanter. But so if you have a reverse trochanteric fracture, classical reverse trochanteric fracture without comminution, then a TSP is the best option. Because all it does is buttresses it and then stops medialization. Okay. If you have a comminuted trochanter which is off, gone posteriorly, then you have to wire it back. Whether you use a TSP or not is secondary to the fact that you have to get this trochanter back into position and wire it. Now, the wire is not as effective as a TSP in terms of buttressing the medial. So in the sense that it's not as good a buttress, but it's like it functions to hold the trochanter in place. It doesn't prevent medialization that much. So if you think it's something that is likely to medialize, then you're probably better off to also add a TSP to the wiring system that you've done. Okay.
So, Rajan has asked about what is positive and negative reduction and how much it is important.
So yes. So what is positive reduction and what is negative reduction? It's a bit difficult to explain it without a diagram. But basically, if the calcar abuts on the shaft, that's a positive reduction. If the calcar goes into the fracture, that's a negative reduction. And if it is exactly where it should be, that's a neutral reduction. Okay. So the Wayne County, this was described many, many years ago and was described as the Wayne County reduction when you did a DHS. Today, people talk about positive, negative reduction, but this is something which is not new. Okay.
So,
Milan Joshi.
Milan Joshi, sir, he is asking. So sometimes you will add a TSP and a wire for trochanteric if it's needed. Is
Yeah,
that right, sir?
absolutely. Yeah. We combine the two sometimes. Yeah.
Yes. So when you go straight forward for the open reduction in case of subtrochanteric fracture, like when you are doing the nail, and when we put the nail and
So subtrochanteric fractures, there are two options. We are more in favor of the nail in most situations, but we use the minimally invasive plate sometimes. Okay. So you can slide a plate in, especially if there's a lot of comminution in the trochanteric region, because when the plate goes in, it actually just holds everything together and it's an anatomical plate. So if you get it right, it kind of helps you with the reduction of the anatomy. But having said that, that was a phase we went through where we used a lot of plates. We're not doing it as much. The hip plates are no longer available, which Smith and Nephew had earlier. The Smith plate of the hip plate of Synthesis didn't work very well. So we used the distal femur plate of the opposite side. So that doesn't always fit in anatomically. So we use it more for non-unions and late presentations rather than fresh fractures. So fresh fractures, we tend to go for nailing more often than plating.
sir, how often you use bone graft in case of that bone loss in subtrochanteric region if it's fresh fracture?
Never. Almost never, I would say. I can't
Yes.
remember when we last used it.
Okay, so that
So
bone usually
unless it's an open fracture, you should not get bone loss. There's comminution, and this really heals well if you get the alignment right, you get the biomechanics right. So it's never, if it's an open fracture, that's a different thing altogether. But we haven't,
and so
we used to graft a lot at one time, but it's been ages since we've actually used graft for a fresh fracture.
if the fracture is atypical, sir, then your approach
Atypical neck.
subtrochanteric, sir.
Yeah, so I think what is important in atypical fractures is to not compromise on the reduction at all. Okay, so most subtrochanteric trochanteric fractures with a little bit of malreduction, you can probably get away with it. But in subtrochanteric, in atypical femur fractures, your reduction must be perfect. One. Second is some of these patients have varus. Okay, now you have to decide whether you want to correct the varus at the time of your reduction, or you get back the normal anatomy or the pre-fracture anatomy and then deal with any problems later. Now, this is an area of conflict between some people. Some people think that that's the best time to correct the anatomy. The problem with that is then you have to correct the opposite side also. Okay. So, because they feel that the varus is part of the problem of a atypical fracture. Okay. So I would get the reduction right. If any doubt, I would open it. And if any doubt, that is one situation where I might add a plate to a nail. Okay. But that's a rare situation. We don't see too many of these or not enough of these as yet, but I'm sure we'll see more and more. I think 10 years ago, we hardly saw any, while other parts of the country were beginning to see them. Now we are seeing some, but not that many, but the numbers are increasing gradually. So when you guys are, I would have retired by then, but you'll probably see a lot more of them.
Sir, one thing, sir, I usually get confused when there is osteoporotic bone with trochanteric fracture to do the reaming or not before putting the nail, because the canal is already wide. So in such cases, what should
So
be
if
the
the
our
canal
approach,
is
sir?
wide and you can pass your nail without a problem, then there's no need to ream. Huh? But if you have any doubt about the size, that means you want to put in an 11 nail or a 12 nail and you are not sure it will go in, pass a reamer and check. Okay, get a guide wire and check it. Because what you don't want to do is to be stuck, which has happened, where you get stuck in the middle thinking, okay, this nail will go in, and you try to hammer it in and it doesn't go in. And then you're stuck between taking it out, not taking it out. So
It
your nail
happens.
should pass in without a problem, okay?
And sir, in such cases, weight bearing, sir, your advice would.
So we tend to weight bear our patients straight away, whether it's DHS or nailing or whatever. Huh? But you have to get it right, okay? If you don't get it right, then you can't weight bear them. Okay, so we
So how to?
almost all our patients, you've seen that. We don't
Yes, sir.
not get them up and about, and we allow them weight bearing as tolerated more or less straight away.
Okay, sir. So as early
Whether we
as
do a
like
DHS or a nail or whatever we do, we start off early, okay? Because the whole idea of doing this surgery on these patients is to get them up.
yes. Okay, sir. Okay, thank you very much, sir. I think
Yeah,
there is
already.
no
Thank you.
more question. Yeah. Thank you very much, sir.
Okay, sure.
It
Bye.
was great, sir. Great learning.
Sure. Yeah,
Thank you,
so
sir.
it's unusual me to talk about nailing, but it's important.
Yeah, it was
Because
really,
we see
really
a
great,
lot
sir.
of badly done nails, so we need to avoid
Yeah,
that.
true, sir.
Okay.
Yes.
Okay, bye. Thank you very much. Yeah.
Thank you very much, sir.